Welcome. Thank you, Jeff. It's a pleasure to be here. I'd like to thank Varenna for the opportunity of making this presentation. It's always good to talk about what I do. It's actually pretty easy because I've been doing it for like 25 years, and I've been in Santa Rosa since 1985, and I've been lucky enough to be part of this community and part of Santa Rosa Memorial Hospital with a great group of fellow surgeons in a practice that's actually, the name has been in existence since 1946 in the North Bay area. So some of my predecessors laid really good groundwork for me to come into this community and develop a practice. And orthopedics is so much fun because your patients almost universally do well and get a whole lot better. So they're very appreciative. It's rewarding to do a surgery where you see people come in pain or they can't live their life like they want to. And through the techniques that we have available to us and the great equipment that we have, as well as the implant technology, we can make people's lives better and get rid of their pain. And it's so rewarding to have a patient come in 6 months or a year after they've had an implant, a hip or a knee replacement, and they say, "Doc, you know, I don't even know I have it. I don't feel anything. It's like I never had surgery." I mean, not everybody's that lucky, but by and large, everybody is better. I mean, they get great results as far as relief of pain and return to activities, and some people have no awareness that they even have an implant, which is a really cool thing, considering probably as long as civilization's been around. I mean, we haven't had joint replacements until the last 50 years or so. So I don't know how people how they functioned before that, but in this day and age, we certainly have that as a great option. So what I'm going to talk to you about today is more or less what I do, joint replacement surgery and techniques for treating arthritis. And I primarily work on hips, knees, and shoulders. So what I do is joint replacement surgery in those categories. I also do arthroscopic intervention for less severe conditions, sports injuries. So we'll do shoulder arthroscopy, knee and hip arthroscopy. I'm fortunate in that there are 8 surgeons in Santa Rosa Orthopaedic Medical Group, and my colleagues have subspecialty training in other areas of orthopedics. For instance, so we have a foot and ankle specialist, we have one hand specialist and another hand specialist coming to join us in September. We have sports medicine physicians, we have 2 traumatologists that take care of major orthopedic trauma injuries as well as back specialists. And we have our own physical therapy department and rehab center. We do our own imaging for x-rays and MRI studies. And we try and provide a full complement of what it takes to maintain musculoskeletal health. So in the United States, there are at least 37 million Americans that are affected by arthritis. It's probably closer to 40 million. And I think that number is probably going to double in the next 10 years because as the baby boomer generation moves into their golden years, it's becoming more and more common. We live longer, we're more active, some of us do stupid things, and that results in arthritis down the road. You pick up a souvenir and then you've got it until it gets bad enough that you need my services. But approximately 1 in every 7 individuals in the U.S. Is affected by arthritis, and 1 of every 3 families. To talk about the anatomy of the hip is a ball and socket joint, whereas the knee is more of a hinge joint. The hip, as you can see, being a ball and socket joint, is more inherently stable. It doesn't depend on the ligaments as much, whereas the knee, being a hinge joint, 2 basically sort of flat surfaces, they're very reliant on the other soft tissue structures around the joint, including the cartilage and the ligaments. So in the hip, the thigh bone is the femur, and then the pelvis provides the socket. That's technically called the acetabulum. Arthritis is a process when you start to lose the normal cartilage and structure of the joint. It can start with an inflammation. It can present in many different forms, but the ultimate end result is loss of articular cartilage, which is the cushion that surfaces the joint. It's analogous to the tread on your tire. And it erodes, and then you lose that cartilage, which you lose the benefits of the cartilage, which is the cushioning and the lubrication that it provides. And ultimately, when it's worn to a certain extent, you get bone on bone, or you get a raw surface of a bone exposed, and that becomes very painful. It's lost its normal low coefficient for friction, so it's rough and it grinds and it hurts and it causes an inflammatory response, which results in the pain that you feel. So again, cartilage covers the surfaces. It's very specialized. It's 80% water and about 20% protein. It provides a very low friction coefficient. It's about 15 times less friction than ice skates on ice, and about 100 times less than a typical ball bearing type joint. So it's very specialized. It's hard to recreate that. The joint replacement surfaces that we have probably are about 30 times greater in friction than a normal joint. So it's hard to recreate anything quite as smooth and as efficient as the joint surface. The cartilage provides cushion. The synovial lining secretes a joint fluid, which is a very lubricating type of natural fluid that helps reduce the friction. So how we measure it on an x-ray, when you come in and see your doctor, your orthopedist, you'll take an x-ray and you'll see if there's any cartilage space. So we see it as a space. And if we've lost that space, that's how we measure how much arthritic wear or change there has been. Normally that space is around 5 to 8 millimeters, depending on the individual, where the cartilage occupies on a knee or a hip. So the most common arthritis is degenerative arthritis. That's what probably 80% of the arthritic problems we see are. It can involve one or more joints. Usually it's a weight-bearing joint, so the most common joints involved are the hip or the knee. Shoulders also quite commonly are involved, and then the hand and wrist. And in the hand and wrist, probably the most common is the base of the thumb. We call it the opposition or the pinch joint because that's so important in gripping it. That's a very common area that wears as well. Rheumatoid arthritis, that's kind of a funny slide. Anyway, it can involve multiple joints. It occurs at any age, more frequently younger than in an arthritic joint, than an osteo or degenerative arthritic joint. So it occurs more likely in younger age groups, more common in women. It can affect the entire body, and again, usually multiple joints. Avascular necrosis, kind of a technical term, but it's a cause for some arthritis too, especially in the hip, because the blood supply in the femoral head of the hip is a little more vulnerable, and it doesn't take a lot to interrupt the blood supply. So certain conditions can do that. If you have a trauma or a fracture, it can disrupt the blood supply, and then the bone dies. Steroids, taking steroid medications like prednisone or cortisone on a continuous basis can cause this also. It's a necessary evil for some conditions. Prednisone used to be used a lot for rheumatoid arthritis. It's used for kidney kidney transplants and other forms of other forms of organ transplants to prevent rejection. So it can cause avascular necrosis. Regular consumption of alcohol is a common cause of avascular necrosis, and some blood diseases also. Probably half the time it's idiopathic, which means we don't know why people get it, they just do. It can just happen for no particular reason. But what happens is you lose the blood supply to the bone marrow, and it infarcts, and then over time it collapses. Bone can't repair itself very well. And so when it collapses, then the joint surface collapses, and then you might even see where the cartilage gets disrupted or malfunctions, and then you end up with an arthritic joint. Same thing as if it was degenerative arthritis. The end result is pretty much the same. Developmental dysplasia, having a condition of abnormal anatomy from birth, can certainly lead to arthritis. It's more common in the hips. Like this is a hip here that didn't form in the right socket. It's subluxed, and this is way off. Usually it's much more subtle than that. It's either an abnormally developed socket or the head's migrated proximally. And that will wear, and at an early age, people will start having problems, and then they will have requirements for joint replacement type surgery. Trauma is a common cause for arthritis as well. When you've had trauma around a joint, that leads to a souvenir that ultimately will cause wear and tear on that joint, more rapidly or accelerate the wear process where at some point you'll have arthritis. Sometimes it's right away, within 6 months to a year. Sometimes it might take several years for that arthritis to evolve after you've had trauma around a joint. Infection is a less common cause, but once in a while people will get an infection in a joint, and that is detrimental to the cartilage. It will cause erosion of the cartilage and can lead to arthritis as well. So what we do when the patient comes in to see us, we'll do a physical exam, of course, get a history also. If people are having pain while they're weight bearing, if they have stiffness in their joint, if they have a limp, those are signs of arthritis. We'll use different tests for diagnosis. X-ray is the most common test we use. We'll take a picture, and if we see signs of narrowing of the cartilage joint space, or we see a hardening of the bone, like this is sclerosis of the bone, it gets extra hard, it'll show up as a whiteness on the X-ray. And then sometimes you will see cysts in the bone, and that's a reaction. The black holes are cysts in the bone, and that's a reaction to the arthritic wear, the inflammation. The white cell response just causes sort of erosion of the bone structure around the joint. We'll do additional tests as well. Someone with an inflammatory type of arthritis like rheumatoid or lupus or psoriatic arthritis will have blood tests to determine that. We look for elevated SED rates, anti-nuclear antibodies, or rheumatoid factors, which will show up on a test. And again, we already discussed avascular necrosis. And just with arthritis as well, we'll do other studies as well than just x-rays. A bone scan study will light up a joint. It's a radionucleotide, sort of a test that's done to pick up inflammation in a joint, or a metabolic study, so to speak. An MRI is probably more sensitive than an x-ray picking up arthritis. It'll show the soft tissues. It will pick up more subtle changes before you actually see them on an x-ray. And then sometimes we'll put a needle in the joint and take the fluid out and do a fluid analysis for certain conditions. If you're looking for inflammatory arthritis, gout crystals for gouts, or calcium crystals, and or an infectious process, typically we will aspirate the joint and send it for analysis. When people come into the office, we don't immediately sign them up for an operation. I mean, usually we try other methods of treatment, because many times an arthritis problem can be managed without surgery, at least in the initial phases. I mean, you may be able to forestall having surgery for several years or longer. So first thing we'll do is try and modify their activities. Maybe instead of high impact activities, have them learn or teach them a way to be more, to be active in a less detrimental way to your joint. Avoid some of the higher impact activities, deep squats, deep lunges. Pursue things like cycling, swimming, low impact exercise in a gym with equipment. So physical therapy becomes involved in part of that process. Mainly to just get someone started on a program that they can continue on their own. And again, we talked about activity modification. One of the biggest problems we face, at least in the US, is obesity. The weight is a problem. If people carry a lot of extra weight, their joints are going to hurt more. It's just the way gravity works, especially the weight-bearing joints, your hips, knees, and feet. So sometimes just going on a weight loss program, dieting and exercising properly can make a huge difference. Some people are in a category where that isn't going to work. They're way too overweight, and then we will refer people to a bariatric specialist who may do lap band surgery or some method of treating your obesity problem with surgery. And people can lose, they can drop 100, 200 pounds. If somebody's in the 300-pound and plus range, they really have to lose have to lose weight before they can safely have surgery. We like to have someone 200 pounds or less. It just reduces your risks associated with the surgery and improves your success rate and your outcome. So those are things we also address. And then walking aids. I mean, most of us don't really want to go around with a cane or a walker. So there are other ways. I mean, like I send a lot of people to pick up hiking sticks at REI. You can get nice telescoping graphite hiking sticks that can make a huge difference if you're not taking hikes because your hip hurts or your knee hurts. So that enables you to be more active. Simply using a walking stick as a hiking pole on the opposite side of a bad hip can reduce the stress on that hip by about 70% and make it so that you can be more active. You can hike trails and do them where you work, you would have been reluctant to without that. And then we get into the medication arena where we will use anti-inflammatory medications, either over the counter like ibuprofen or Aleve, which are probably about as good as any, but then there are prescription ones as well, and they can be helpful. And sometimes you just take them on demand. It doesn't mean you have to take them all the time, but if you've got a trip planned to Europe, or you're going to go hiking in the Sierras, or you're going to be more active, you take it before, during, and after those activities. And then there are also pain medications such as painkillers like opiate medications, Norco, Vicodin, and Percocet. Those are controlled substances, but they're helpful too, but maybe not on a continuous basis, more like on demand if you've got a lot of pain and you can't get comfortable. We will add those to the mix as well. And then there are a lot of claims made by supplements like glucosamine, chondroitin sulfate, MSM. It's hard to say whether those really work or not. There's no absolute hard clinical proof that they work. It's not really controlled by the FDA, so people can advertise and say this is going to cure you, make your pain go away, and restore cartilage. And there's really no scientific basis for that. Sometimes it helps. I tell people if you want to, give it a try. It may help, but I really can't tell them that it's going to correct their arthritis or reverse the process. So non-operative treatment as well that we use are injections. We'll use cortisone. It's still a great drug. When I'm in the office, I'll give a dozen or more cortisone injections a day. It's Depomedrol or Kinelog. It's a form of a steroid. Very good anti-inflammatory, works really well for an inflamed joint, gives good temporary relief. No, it's not a cure, but again, if you've got some activity plan, a wedding out of town, a trip somewhere, and the ingestion can make that experience more comfortable for you and more fun, so you're not having so much pain. So we will use injections intermittently. We also use viscosupplementation, which is the lubricant that your joint normally has in it, that the lining of that joint makes, that it starts to lose its capability of doing when it becomes arthritic. So we supplement that by injecting this gel that, again, lowers the frictional coefficient, makes the joint feel better and function a little bit better. It doesn't always work. It probably helps people 50 to 70% of the time. But it's not surgery, so many times we will try that before we go on to surgery. It's helpful. And there are several different brands on the market, Hyalgan, Orthovis, Synvis, Suparts. And again, it's just another thing we have in our arsenal to treat the symptoms. And then platelet-rich plasma, there's a lot of hoopla about that. That's recently starting to hit the press, and hard to say. It's hard to say if that works for sure, because there's just not enough scientific data out there with controlled studies to prove whether it works. And PRP, or platelet-rich plasma, is basically taking your blood and spinning it down and condensing the platelets, where you get maybe 10 times the normal concentration that you would have in your blood. And it has growth factors in it, and maybe some stem cell component that are healing factors and can help tissues regenerate or heal. It's used frequently in tendon injuries, like tennis elbow or Achilles tendonitis. For arthritis, we're not sure. I mean, it's still investigational. It might have some application, but it's probably going to be more helpful in somebody in the early stages of arthritis. Once you've got enough wear of that cartilage where the cells are gone, or you've got exposed bone, it's not going to do a thing. It might have an application in the early process or early development of arthritis. But because it's still investigational, no insurance company is going to pay for it. I mean, Medicare won't cover it, and no commercial insurances or workers' compensation are going to pay for it because it's relatively expensive and nobody knows that well that it works or not. So then we get into the operative arena, and these are some pictures of different types of implants. But one of the things when we assess a patient, well, what needs to be done? If it's a knee problem, you may not necessarily start off with a whole knee replacement, the whole thing. It might be that you can do well with just a partial replacement or resurfacing one part of that joint. The knee has three parts: the kneecap part, which is the patellofemoral part, the medial, and the lateral. And sometimes people's disease is isolated to just one part, probably about 10% of the time, 10 to 20. I'd say 80 to 90% of the time the whole joint's involved. But when it is just part of the joint, we can resurface just that part. And so this is a resurfacing for a patellofemoral. That's the groove the patella will glide on, and then the patella gets a new surface also, just a dome of plastic. Because most joint replacements consist of two surfaces contacting each other. One side is a metal type of alloy, and the other side is going to be a plastic. I mean, you've probably, most of you are here, you're aware of some of the recalls that have occurred in implants where we tried other surfaces that don't always pan out, like metal on metal had issues. You get ion wear and issues with that were bad. So we've gone back to what we know works, and pretty much the gold standard is some form of metal on one side and a really durable polymer plastic on the other side. And anyway, that is for the kneecap, this is what the x-ray looks like. So that's that implant that's in the femur, and then the kneecap itself got resurfaced. So that's just part of the joint. This is for the medial compartment or the lateral compartment. So it's not the patellofemoral, this is the other part of the knee down below where you might just replace one side. And again, you're not taking away much bone to put that in, just maybe 5 to 10 millimeters of bone to put that in. And the advantage of using a partial is you don't really disrupt any of the ligaments in the knee. You preserve the ligaments and all the soft tissues. You're just resurfacing the bad part of the joint. And then total knee replacements or a complete knee replacement looks more like this, where you're going to recap the entire joint surface. So sometimes when people come in, I go, well, I don't want my knee replaced. People think, well, they're going to just chop it here and chop it here, and I'm going to get something all new, you know, like an artificial leg. But it's really just resurfacing the joint. That's what a knee replacement is, because it's the knee joint replacement. So you're replacing the joint, which technically is the joint surface. So even for a knee replacement, you're only removing 5 to 10 millimeters of bone on the surface, and then you're recapping it. So you're recapping all the bearing surfaces of the joint, the femoral part, the tibial part, and then the patellar part. And you're preserving most of the ligaments and certainly all of the tendons and muscles around the joint. So it's really resurfacing the joint. Doesn't mean it doesn't hurt, and it's not a process to get over, because it is. It takes a bit of recovery, but that's really more a better description of the procedure. And then in the hip, there are different ways of dealing with the hip, but resurfacing is one method which has been popularized in the past and still is used in certain indications. I studied it. I went back and did cadaver procedures with that. And it sounds good. It's one of those things that sounds better than it is. It's resurfacing the joint where they say you take less bone away. But in actuality, it's a bigger operation. It's longer. It's more blood loss. And the results, the long-term results, aren't as good as a contemporary hip replacement, because the hip replacement designs have been improved so much that they're much better. They're bone sparing. One of the reasons to consider doing a resurfacing is you take away less bone. For younger people, that means you're going to have better options down the road when you have to go back maybe and redo it. But again, the contemporary hips really don't, they preserve bone anyway. The resurfacing hips have a higher failure rate. The longevity is not as great. So I typically don't recommend them. So then I would go on to the next option, which is a hip replacement. And this is an example of a contemporary hip. This is made by Zimmer. And the product, the materials, like that's a tantalum alloy, which is next to titanium on the periodic table. This is titanium. They're porous surfaced, so that the bone grows into them. We don't really use cement, hardly ever on a hip. We still use cement for knees because they just work better. But in the hip, we typically use something that is biocompatible. The bone grows into it. You can see that this has got several parts. It's got the outer shell. It's got the polymer plastic. It's got the head, which is a real hard cobalt chrome molybdenum alloy. It's got the neck, which is actually modular, and that is titanium. And then this is titanium, the stem. So there are actually 5 parts to that hip replacement. And the nice part about the modularity, if any part ever wears out, you can maybe just replace the part that wore out, not everything. And the other option, the other thing that it provides is there are like 60 combinations of how you can have this neck go into this, different shapes, anteversion, offset. So you can really customize that hip replacement at the time of surgery. You can get it the right fit, so you get the leg lengths equal, you get the stability correct. And the implant technology has made our job a lot easier and uniformly made the results better. And to talk about brands, you'll see different companies advertise. It's annoying to surgeons because people come in with a preconceived notion sometimes about what's the best implant, and it's like watching a car commercial, you know, like a Chevy, a Ford, or a Chrysler, you know, and that's kind of the way implants are. I mean, there are 3 or 4 big manufacturers, and all the implants are very similar, and they're all pretty darn good. So here's an example of a hip replacement. The most commonly used procedure is a posterior approach, the traditional posterior approach, a little longer incision, a little bigger operation. And again, this is that tray with all those modular heads, so you can see when we have options, we have a variety of things we can use to make that fit correctly. So more recently, the anterior approach has been popularized. I've studied it, I've done some. I'm not a big advocate of anterior approach hips. Anterior approach hips is not something brand new. I learned how to do those when I was a resident, which was a few years back. And it's been revisited, it's popularized. It's still not I would say, the gold standard for hip replacements. It's still a minority of the way hips are done. But it's very popular. It's been marketed quite extensively more recently. The bottom line is, which I'll get to next, is the small posterior incision surgery, which is what I do. It works very well, and I think in a lot of ways has advantages. They both are successful. I'm not going to say that anterior hips don't work well. They do. The thing is, the technology and the techniques that we have, hip replacements work very well no matter what you do. The success rate is in the 95 to 99% range. So, but to talk a little bit more about the anterior approach, it separates the muscle tissue instead of cutting across it or through it. You still cut through the ligaments and the joint capsule, and you're cutting through the biggest bone in your body. So it's still somewhat traumatic because the femur is the largest bone in your body, and you've got to cut through the neck of the femur, and you've got to prepare the socket or the acetabulum. The recovery time is good. Maybe some of the downsides for anterior hip, I think in most surgeons, it's a longer operative time. A longer operative time typically leads to a little greater blood loss, and when you have longer operative time and greater blood loss, it correlates with higher infection rates. And infection can happen no matter how you do the surgery, and the infection rates, fortunately, are low. I mean, they're way less than 1%. More in the neighborhood of 1/10 of 1%, or 1 in 10,000. The long-term comparative data is still out there. When anterior hips were popularized, they were comparing the results and the recovery with the way surgery was done posteriorly maybe 10 or 15 years ago, because that was the literature they were comparing it to. Well, that's not quite a fair comparison because posterior hip surgeons have improved their process as well. And you're adjacent to the femoral nerve through an anterior approach, so it's a little bit more vulnerable to injury. And again, anterior approaches are not optimal for all patients. Some body types it doesn't work well on. And if you have a complication or a problem, you can't address it very well through an anterior approach. As a surgeon, we like to have the option to deal with a complication, and it's better with a posterior approach. Also, if you're doing a revision surgery, most orthopedists are going to tell you if you have to go back for a revision, you're going to have to do it posteriorly, so you're not going to be able to use that same incision. Most of the time, revisions will require a posterior incision with a little bit more extensive exposure. So this is what I've been doing for the last 10 or 15 years. I studied in Chicago with Richard Berger doing the 2-incision approach, minimally invasive. I went back to the Warsaw Institute in Indiana and in Las Vegas and studied the variety of approaches, including the anterior approach. And then also studied with John Dearborn at Washington University, or Washington Hospital in Fremont, and he does a very high volume. And he is probably one of the local pioneers of the minimally invasive posterior incision, and I more or less adopted his techniques and felt that he got really good results, and to this day that's still how he's doing his hip replacements. So here's an example of how we do the surgery. That's the incision, so that's the femoral head being removed. You can see how small that incision is. It's about a 3-inch incision. So you've got a mobile window that we can move around to get access to what we need to for the exposure. The instruments are modified to allow us to do it through a small incision. And so that's the extent of the incision for this patient who we did, I don't know, he's within the last month. I just took a photo while we were in doing the procedure. And then that's the incision at the time of closure. It's about 3 inches, 3.5 inches long. So you can do it through a small incision. You expose less tissue. The muscle you cut through is really minimal. You're cutting with the grain, so to speak, in line with the grain or with the fibers of the muscle. So you're just kind of splitting it, and you repair it. And so it's typically a little faster, the less bleeding. You don't have to use x-rays, so there's no x-ray exposure. And I think the results for me are more predictable in an anterior approach. So I think the perceived benefits for an anterior approach don't outweigh the risks. And I think they're both successful procedures. So I think they both work really well. What you want to do when you're looking for a surgeon and having a procedure done like that, you want to talk to friends and people who've had an experience with that surgeon. What's his track record? How many does he do? And what is the hospital facility that he uses, and how many do they do? You know, if they're structured so that they do a number of those procedures, it becomes more routine and the results become more constant, you know, that the results are going to consistently be good. And you also want to go somewhere where they're going to follow you. You know, if you go out of town, you go somewhere else, well, it's like a factory. They treat and street you, and you know, they're not there for your follow-up. I'm a firm believer that you should have your surgery in the community where you live, as long as those services are available to you and they're good quality. And that way, if you have issues, if you have a problem, they're going to be able to respond to you. And we have three really good hospitals here in Santa Rosa. I'm not a member of Kaiser, but I think Kaiser is a good medical hospital and delivery system. Memorial Hospital is where I do most of my work. I'm adjacent to Memorial, and they do total joint replacements every day, at least 5 days through the week, Monday through Friday. And they do a high volume. And they have a very good program. There was some literature out front as far as classes that they have that are educational. And if anybody's interested, they're open to the public, not just for people that are scheduled for surgery. And then Sutter Hospital does a large volume of joint replacements as well. I work there as well, as do most of my partners. And as you know, they're building a new state-of-the-art hospital near the Burbank Center, and I'm sure that they will continue to prosper and grow. And Sutter has a great track record as far as their capabilities with joint reconstruction as well. So here's a picture of that patient that I showed you the x-ray, I mean the operative procedures, the one just before with it showed the OR pictures. This is his x-ray before. That shows how there's no cartilage there. We template the sizes we need, we anticipate what we need, but we have the full inventory of everything we need when we're there. There's all the sizes, all the shapes, all those configurations are all there in the operating room at our disposal when we do the surgery. So it's not like we have to order it ahead of time. We just like to have an idea ahead of time what we're going to be using. And then when we're in there, we will do the final measurements, and we do trials and test fit and do range of motion to make sure that we have the right combination before we actually do the final implant of that prosthesis. So when you go, so that's all good. You finish your surgery, then what's it feel like afterwards? Well, there might be a little discomfort afterwards, but we try and minimize that, and we've gotten much better with our techniques. The anesthesiologists are on board with improving everybody's experience during the hospitalization, less pain, quicker return to function and mobility. So most of the surgeries are done with the spinal anesthesia, and in knees we'll also add a regional block where we put a catheter in and block the femoral nerve. We also inject the back of the capsule of the joint with a long-acting anesthetic, so that for the first 24 or 48 hours there's not too much discomfort with the knee replacement. With the hip it lasts about 12 to 24 hours because we don't have a continuous catheter in. But then once the anesthesia does wear off, then we use medications, long and short-acting pain relievers. But we've been able to reduce the amount of pain relievers we need as far as the pills and injections go. And that helps because you have less nausea, less constipation, which those drugs cause. And also you're thinking more clearly and you're able to get up and move better if you're not drugged too much. So we've been able to work on that and improve that process. We also use a blood recycling system. So the people do not pre-donate for their surgeries anymore. We used to have people donate blood ahead of time and then they got their own blood back after, you know, if they lost enough. But we don't do that anymore because with the small incision surgeries, we lose less blood, and we also have a mechanism of recycling that blood within the first 12 hours. So you get your own blood back. If needed. You know, most of the time people don't even lose enough to make it worthwhile giving it back, but we have the mechanism there for that. Also blood clot prevention, we've improved our treatment in that category as well. People used to either go on Coumadin or they would have to give themselves injections in the stomach or in the abdomen for the first 2 to 3 weeks. Now I have gone to just a pill. It's called Xarelto. It's an anticoagulant that you take once a day. It's made by Bayer, same people that make aspirin. But it works, I think, better than aspirin. And it's once a day, a pill that you take for 2 weeks after a knee replacement and 3 weeks after a hip replacement. And the emphasis after surgery is to get people back on their feet and getting them moving. That's what the whole process was about to begin with. So we work on balance and strengthening. And you will need maybe some aids to get around to start out with, like a walker or a cane. But as soon as possible, we get you off of the assistive devices as well. And all of these implants are made to be full weight bearing right away. It's not like we don't allow you to put weight on it. It's just you need a little help with your balance and for comfort. But they're all designed to bear weight immediately. And then physical therapy after you go home from the hospital. You may have therapy at home. We can arrange for them to come to your house. If you are somewhat housebound, it's just easier maybe the first week to do it at home or where you live. And then pretty much after that, you're ready to go into the gym where you come into a physical therapy facility and you work out on equipment, stationary bicycle and leg press machines, things to help get your strength and work on getting your range of motion back. And then you'll follow up with your physician or your surgeon, usually at 1 to 2 weeks after you go home, and then again around 3 months, and then maybe 6 months. And then many times we'll follow people every once a year or annually for a joint replacement, or at least every 2 years. We also advise people to take antibiotics before and after dental work to give you some protection or prophylactic protection against an infection when you have your gums manipulated. So we tend to do that. Some surgeons do it for 2 years. Some of us like to do it just for a lifetime. If people have no problem taking an antibiotic, you know, an hour before and 6 hours after they have their dental work done, it just gives you a little extra protection. So what makes my job all worth it? Well, I kind of stated that when I started. It's basically getting people back to the things they used to like to do, what they love the most, and getting rid of their pain and improving their lifestyle and their quality of life. So I've got a few patients here that said they had a good experience. I mean, these are just a few of them. This fellow likes to fish. He had, I think, a hip replacement. This lady and her husband, they're big cyclists. They like to go back to Sturgis, South Dakota to the big motorcycle rally every year. She's got both hips replaced. She was hardly able to walk when she came in. And you know, I think I did her hip replacements about 5 or 6 years ago. And she sent me this picture from, I think that might be from Yosemite. But anyway, they like to bike. These two ladies both have knee replacements. One has bilateral knee replacements, and they are on Patrol and Anadel. And this lady is, she's had her hip replaced. She's an avid tennis player and was able to get back out on the court. And many of my patients are able to get back to activities like cycling, golfing, skiing, snow skiing, playing tennis. Some people that actually play senior baseball. So they can be quite active. That's the whole goal. So thank you for your attention, and I'm open for any questions.
If you have a partial knee replacement, what are the odds that you'll, oh, thank you. If you opt for a partial knee replacement, will you ultimately need to have another surgery? And if so, what would the time frame be?
Yeah, so that, did everybody hear the question?
Yeah.
You obviously don't want to put it in and think that well, a year later or two we're going to have to convert that to a total. So it depends on the individual. That's why you have to be very specific about that the disease and the symptoms are only on one part of the joint. And many times I'll do an MRI rather than just x-ray to make sure that I've looked closely at the rest of the joint compartments to make sure that truly it's only the one part that's causing the problem. And if that's the case, then it's a good option. It's less surgery. It's about twice as easy to recover from as the whole joint resurfacing. And it might feel a little bit more natural to you because you've kept all your own ligaments. And you haven't sacrificed any ligaments. So the proprioception and the sensation that it's just you and not something artificial is a little better. So the goal would be that it would last at least 10 years. I'd say in my mind, I would think that if I'm going to do this, I'm hopeful that it's going to last at least 10 years before we have to do anything else. Otherwise, I don't think it's worth it. Some people, though, that are older, we might fudge because maybe they're a little medically compromised and we worry about their risk factors with surgery. It's a little easier recovery, so you might factor that in. But in general, I would say at least I would expect it to last 10 years. Sometimes the rest of that person's lifetime. If you have to go back and revise it or convert it to a total, it's not too hard. It's not like doing a revision of a total joint replacement to another total joint replacement. It's almost like doing it for the first time when you do have to do that second procedure, when and if you do. Yes?
Would you speak about the control of pain from arthritis? Any methods of control?
You mean like management, non-surgical management for treatment of arthritis pain? Well, rheumatoid arthritis, I don't know if you're talking about rheumatoid or degenerative osteoarthritis. Degenerative. Well, which is what I talked to a little bit earlier, there are medications like I think over-the-counter medications, Aleve and ibuprofen are pretty good. There are prescription anti-inflammatories like Celebrex, Mobic, Naprosyn, Voltaren. There are a lot of others, that Relafin, and they may have some improvements, but not great. You know, I think ibuprofen and Aleve or Naprosyn are good over-the-counter options. Some people that have stomach issues or that are on blood thinners can't take those, so they can take Celebrex. It's a one-a-day medication that's an anti-inflammatory also. You see it advertised on television. It's a good product also. But those are pills. For hands, there's transdermal creams that work pretty well, some of the smaller joints. And if you don't tolerate the anti-inflammatories because they can be rough on your stomach and cause people that have ulcers or gastritis, stomach issues have trouble with those. So there are cream forms of them, and it has a carrier that will penetrate the skin and penetrate those joints with anti-inflammatories, analgesic meds, and anesthetic meds that can actually reduce symptoms, especially in the hand, wrists, and maybe shoulders. Then we do the injections. So, and then they're long-acting. If your arthritis is horrible, you can have long-acting opiate medications like fentanyl patches. But those are narcotics. So it just kind of depends on the spectrum of your symptoms and how much pain relief you need.
Exercise or ice?
Ice is always good. Rest, exercise, compression, elevation, and ice. Always good.
Was the hand cream over the counter?
Well, there are different preparations. There are not. There's a Voltaren gel, which is one that's commercially available. There are lidoderm patches that put lidocaine, which is a numbing medicine. There are compounding pharmacies that will make preparations with multiple agents with a carrier. They probably are the most effective. They're a little bit more expensive. Sometimes your insurance covers those and sometimes it doesn't. But I've had pretty good success with those. So the question was the success rate for hips and success rate for knees and issues of having to go back for surgery. And I think hip replacements, I stated, were 95 to 99% successful, a little higher, I think. I mean, and success is variable. I mean, you can have great success or you can have medium success, but I would say people that feel like it was worth it, their life is better, their pain is mostly gone, I would consider that a success. Some people have 100% relief of pain, other people don't have quite 100%. They still have some issues, but they're much better than they were before surgery. So I would put people in the 95 to 99% category of being better off for having had that procedure. Knee replacements, maybe not quite as high as hips, but pretty close. I'd say the 90-95% range. Now, there can be issues that we deal with. One of them is a stiff knee. And there can be various reasons. So I think that's what you were alluding to, was people that had to go back maybe to have that knee manipulated because they didn't get their range of motion. It was too stiff. Sometimes that's a problem we encounter. And there are various reasons for that. One is how we did the surgery. Did we balance the ligaments right? Did we make that knee too tight so it's too hard to bend? Then that knee can be a little stiffer, and if people are struggling getting their motion, you might have to take them back under anesthetic and manipulate the knee to free the scar tissue. And you need to do that within the first couple of months if that's going to work before it gets mature. If you put a knee in too loose, well, they get their motion very easily, but then that knee might not feel stable. It might be a little wobbly, and so it's we try and balance those issues. But sometimes we have to deal with a stiff knee, and we will do that. We'll manipulate it. Rarely will we have to actually go back and open it up to change something surgically. So that's one reason for a knee being stiff. The other reason is people don't get the rehab they need, so that's why you need to be followed up by your surgeon. He needs to keep track of you, know whether you're progressing like you should or not, because sometimes you have to increase the pain medication, increase the therapy, so you can get through the process and end up with a good knee. So sometimes that puts me in the position of being kind of like either a cheerleader or a masochist, because I threaten them. I say, well, if you don't come around, we're gonna have to take you back to surgery and manipulate your knee, or and I'm encouraging them at the same time, because you need that input, so you get them through that process till they get to a point where then it's smooth sailing. But sometimes we have that issue. Yeah, standing up there.
Yes, can you tell me what your advice is on doing both knees at once or both knees separate? And the second question is, will people notice the weight of the actual mechanism inside their knee?
Two good questions. So the first question was doing one or both sides at the same time. I will do that. I have done that numerous times where I've done both sides. It takes a special patient, somebody that's not wimpy, somebody that says, I wanted to get it done at once, and also somebody that's reasonably fit, not somebody that's really overweight, or not somebody that has a lot of medical issues, because the risk factors are probably a little higher of a complication when you do both at once. But the advantage is you get it done and you don't have to go back for another surgery. So it certainly is done, and we do them in the right circumstances. It depends on what the patient wants and what I feel is safe for the patient, but we will do it that way, yes. And then the second question was?
Do you notice the weight of the device?
Oh, usually not. Most of these implants are pretty light. Like I wish I asked the rep to bring some of the implants here. They vary, but the titanium and the tantalum implants are very light. A typical implant might weigh 1 to 2 pounds. So not a lot. But I do have to tell you, I had one patient that he had an older design hip and he had special issues, so he had a really long stem prosthesis, a different kind of alloy that was heavier. He had both hips and both knees done, and he was very lean, and he jumped into the deep end of the pool one day, and he said he almost drowned because he really sank to the bottom. It's like somebody tied a piece of concrete to him, but that's rare. Usually you don't notice the weight. I have a great, not to talk about myself, but I got a second opinion story that I like to tell. When patients ask for a second opinion, I don't get upset. Used to you take offense because it's a little bit of a dent to your ego, but it's really the patient that needs to be happy and satisfied. And I don't always have all the answers, but I broke my ankle when I was in college over Christmas break on a sledding accident. I hit a frozen bank, broke my ankle, went to the local doc, he put me in a cast. I go back to school, it was at Indiana University. Within 2 or 3 weeks, I totally destroyed the cast. There was nothing left of it. So I go into the Student Health Center, and he sends me to a local orthopedic surgeon in Bloomington, Indiana, who goes, this is like now, it's been a month or so after my injury. And he goes, oh, that looks horrible. He took an x-ray. We're going to have to operate on you. We're going to have to open up your ankle on both sides. You're going to be in a long leg cast for about 2 months after this. And I'm going like, holy cow, I don't really want to do that. So I went to get another opinion, and I went to the university, which was in Indianapolis, the medical center. And I saw the 2 pediatric orthopedists there. The first guy comes in, looks at my ankle, brings the other guy in, he looks at my ankle, moves around a little bit. He goes, well, are you planning on playing professional football? And I go, no. And he goes, well, you're fine then. You don't need anything. So in other words, I got an opinion that said, you need this, surgery, and I got another opinion that said, goodbye. So, second opinions can be worthwhile. Yes?
Are years of running, for example, 30+ years, detrimental to the body in terms of arthritis or any other
That's a really good question. Is running detrimental to the body for 30 years? And I really don't know the answer to that. I mean, it's an interesting concept because running in some ways is good for your body. But I mean, if you start to have symptoms or start to have pain with running, then you should pay attention to it, because at a certain point, if you've got some arthritic wear in your joints, it's bad. You're better off doing low impact stuff. But some people can maintain running for into their 70s and 80s. And I know there's this book called Born to Run, which is a great book. And it talks about running barefoot and how Nike and running shoes have kind of destroyed the foot, where people did better without the kind of support in their foot. So there's different opinions about just what shoe wear even to wear. But I think running is healthy. Overall, I would say if you're if fit, and somebody that weighs 200 plus pounds and they go, I'm going to start jogging. No, that's not a good idea. If it's something you're used to doing and your body's accustomed to it, I think it's very healthy to do as long as you can do it.
I have two questions. I've heard about the striker get-around knee, and I'm wondering, is that different than other knee replacement things? And also, I know I'm allergic to metal, and that terrifies me. I have bone on bone in both knees. So what can you do if you're allergic to metal, or would I maybe not be allergic to titanium? But I know I am nickel and all kinds of other metals. I can't wear jewelry, etc.
That's a tough question. If you're allergic to metals, I mean, you can have testing done with an allergist and see what you're allergic to. And most of these metals are a pure element, like titanium or tantalum. Yes, I've never seen anybody have a reaction to that. The problem with them is they're soft, and so they're the part that grows into the bone, but the contact surface has to be real scratch resistant. It's a harder alloy type metal, and it has cobalt, chrome, and molybdenum in it. Maybe a trace of nickel, And so that's usually, I think, what people are allergic to is nickel. And at some point, I think you just bite the bullet and do it. I mean, I've never seen an allergy cause that much trouble, to be honest with you. It's not like you're going to have a serious reaction. It might be an annoyance, but usually not. Even if you're allergic, it's such a small amount, and you may not even be aware of it. I mean, but for us, legally, when somebody comes in and I'm allergic to this, and then you put it in them, you kind of assume some liability as the surgeon. But in a practical sense, I don't think it's as big an issue as we've made of it. And I think a lot of times when people thought they were allergic to the metal, it actually maybe turned out to be an infection instead, some form of low-grade infection that's maybe a little hard to culture the organism. So that's what I would say to that. You can be tested, but I think that most of these products don't have that much nickel in them and should be okay. The second question was about the striker get-around knee. Well, I'm from a bias and I don't use striker implants, but striker is a big advertiser, like most of these implants companies are, and they advertise to the public, and they advertise on TV, like a Ford, Chevy, and Chrysler commercial, and they're really all pretty similar. They're pretty similar, so I can't say that one has an advantage over the other. There are different styles that are tried, and when you're talking to your surgeon, you're probably better off trusting his judgment to use what he uses on a regular basis, because they're all so similar that you want that surgeon to use what it is he's comfortable with. The brands don't really matter that much, to be honest with you. And you have to be careful. Some of the brands that are introduced, again, once in a while get recalled. So you want something that's state of the art, but also has a track record. The question was using a ceramic material on the surface weight bearing, or the bearing surface of the implant. And ceramic is a fine material too. I didn't mention it. I use it once in a while. They had designs that had ceramic on both sides. So it was called ceramic on ceramic. So the socket side would be ceramic and the head would be ceramic. And I think those had some issues. I don't know if that's the kind he had or not. Some of them have stress loading on the edge, or edge loading, which causes a problem. They can crack. They're a little more fragile. They had a batch of ceramic that was recalled a few years ago. That hasn't happened recently. So they're okay. But also what's used a lot is a ceramic head on the plastic. Instead of the metal head, you can use a ceramic head. And like the question with the allergy, that was for a knee, though, your knees, not the hip. On the hip, you could probably use a ceramic head and get by without any nickel, because the other parts are tantalum and titanium. But on a knee, you still got to have one side that's the harder metal, which has maybe some of those alloy elements in it. But to get back to your question, what's more commonly used in younger people is a ceramic head instead of a metal head against the polymer plastic or polyethylene. And I use that sometimes for younger people. It's maybe, and the reason for it instead of the metal head is the ceramic head might be a little more scratch resistant so that it doesn't get a scratch on it. And then when you start getting a scratch, that's when you start to have wear particles. And so it just may be slightly better. But I don't know that there's been a long enough study to say that it's really better or not. Because
yeah, he claimed that the ceramic material has been improved quite a bit in the last few years.
yes, it has been improved. And it's a good surface too. So I mean, it definitely is.
Hi, Dr. Stein. I'm already scheduled with you next week. I have two questions, please. Leading up to the surgery, I've been told to discontinue anything that would be a blood thinner, including natural things like fish oil. I'm curious why post-op, when you're concerned about not having blood clots, you want the blood to be thinned then, why can't the patient use things like fish oil instead of having the Xarelto? And the second question is, with using the minimally invasive procedure, can a person cross her legs and bend down to tie her shoes, or is that ever after a no-no?
Okay, the first question about the fish oil, blood thinners beforehand. Well, you don't want your surgeon to faint at the sight of blood, so you don't want a lot of bleeding at the time of surgery. But no, we like you to have normal clotting function when we're doing the surgery, because less blood loss, easier for us to do our job. So that and less bleeding into the tissues, So that's why we have you stop the blood thinners before surgery. If somebody's on Coumadin or they're on Plavix, we will have them stop it a few days before. Fish oil, I never really tell people, I don't think it's that big of an anticoagulant. There are potential, I guess, that it could lead to a little bit more bleeding, but I personally don't have people stop their supplements. I typically just, the prescription style anticoagulants, I have them stop. And then we start at the day of surgery. I mean, that night or the next day, we start you on a blood thinner. But that's the reason, is we just don't want a lot of intraoperative bleeding. If you're really anticoagulated when you come in for your surgery, you're going to bleed a lot, and that creates some issues. So that's the reason for that. And then the other question was, bending over in the positions. Yes. I think they're all the same. I mean, like you can see that the quality implants are so good that we can really get it oriented properly so people's hips are quite stable. Once in a while, somebody will have a dislocation of a hip. Yes, it happens, but it's really rare. It's less than 1%. And so my rule of thumb for people is, I have them follow some rules for about 6 weeks where they don't bend over 90 degrees. But I let people drive at a couple of weeks frequently. They're driving their car. I have people go back to work in 2 weeks if they got more of a sedentary type job. And at 6 weeks, I lift all precautions. You can bend over, tie your shoes. You can cross your legs, no problem. I do tell people when they do really bend over in a full forward flex position that they try and do it in a squared off fashion. They go between their legs, both hands or one hand between their leg, rather than bending all the way over and twisting to the side. So that's really the only biomechanic thing I give people that I say you should try and remember that if you can. And that's really it.
What about golf?
Golf is fine. No problem. One more.
I'm hearing more about these custom knee replacements as opposed to the off-the-shelf ones.
Yes.
Comment on that? That seems to be coming up.
Well, I could go on for an hour about that, but no. So there are, again, it's a lot of advertising, and companies are always looking for their edge. And it's a little annoying because they advertise to the public, and of course, maybe I'm biased. Different surgeons might have different responses to that, but I don't think you can trust a robot to do the surgery. I mean, I think you can't see the forest for the trees sometimes. If it's too robotic and you rely on things that you're not putting your eye on and you don't have the personal experience with, you can get misled. Custom design implants are expensive. Mako's the company that makes them, and their stock went like this because we're trying to have healthcare, we're trying to do things efficiently and effectively and cost effectively. And then you can introduce products that are so expensive that they're never going to catch on, and they maybe serve a niche population, but are they better? I don't think so. And I think sometimes they can be bad, personally. I think you need instrumentation that's proper, you need a surgeon with good skills, and somebody that does a lot of those procedures. But some of that custom, I mean, and obviously technology moves along, and so there are improvements there. I don't mean to poo-poo the whole thing, but I think you have to be, you know, a little cautious about what you read into some of the customized implants.
Well, one thing they really push is alignment, that you can get it aligned right, your knee and all that.
Right. Patient-specific instrumentation. I've seen people use it and throw it away afterwards and then just do it the regular way because it misled them. So you can't substitute your own eyes and your own experience. But you can use things to help you. But again, some of it adds cost. Some of that stuff adds cost to the procedure and may not be worth it. And occasionally can be detrimental. That's my opinion. So.
Thank you, Dr. Stein. Let's give a round of applause.
Thank you.
Thank everyone for coming today, and enjoy your afternoon. Thank you, Dr.
Thank you.